Hey everyone, Dr. Callanan here. I have to apologize for the hair. I just got back from the beach, but I did receive some patients' blood work back, and I thought this was a great opportunity to share a quick rundown of blood work, what I order in my practice, and then we will go through pairing the blood work with the genetic testing so you can see how we can utilize both to determine where you are now with your blood work. What are you more likely to experience based off of your genetics, and then come up with a treatment plan specific for the patient. So as you can see here, I'm just going to minimize my screen. This is an example of a blood report. Now, these values are what we would typically expect to see as Canadian reference ranges. They are different if you are in the US. I try to share both sides and both examples on my YouTube. So this one is specifically Canadian values, but if you are in the US looking at your US lab results, there's going to be a different reference range, but the concepts still apply here. So the first thing we have a look at is the hematology. This is the white and red blood cells for the purpose of this video. We're going to classify this as all normal and skip over it for now. The B12 levels here, they are on the higher end, although many other labs do go up to well over 1,000, 1,500. So this I don't mind seeing in a patient. She is supplementing. I like to see it greater than 500. As long as you're supplementing and over the reference range, not a concern. Ferritin tells us how far away is this patient from becoming anemic, the stored iron. In patients who have overall levels of inflammation, this can be an inaccurate predictor of the amount of stored iron, but it is definitely low in this patient. If we look up at the hemoglobin to get an idea of whether or not she meets the definition of being anemic, she does not meet the classification of being anemic, but she is pretty close given the fact that her ferritin is so low. Now, in my practice, I am focused on getting to the underlying root cause and always asking the question, why? So instead of just diagnosing and labeling this as iron deficiency and take more iron, I need to understand why. Is it because you're having heavier menstrual cycles? Is there blood loss from somewhere else? Are you not consuming enough dietary sources of iron? If you are consuming iron, why is it not being digested and absorbed? So getting to more of the underlying causes is particularly important. This patient we did diagnose as having diabetes based off of her pre-diabetes, based off of her blood result markers here. Now, anybody who has elevations in their glucose and their hemoglobin A1C, you do have insulin resistance when we start to see this. Insulin resistance always comes before we see elevations in the sugar, and the hemoglobin A1C tells us how has your blood sugar been managed over the last 3 months. So it's a 3-month average. Insulin resistance tries its best to keep your blood sugar under control. So we will always see a rise in the fasting insulin prior to seeing changes here. If your doctor is only running a fasting glucose or only running the hemoglobin A1C, this does not give enough information of insulin resistance because you could have a normal average, but really high insulin. So you need to run all three. So yes, this individual has an issue with the hormone response to carbohydrates, and we can look at the genetics to see if there is some genetic influence there. Stress, lack of sleep, nutrition, not moving your body enough, genetics, nutrient deficiencies, poor gut health, many factors that encompass insulin resistance and diabetes. It becomes particularly challenging to lose weight when insulin resistance is present. So instead of just reducing your calories more and more and more, the idea is how can we improve the hormone response to foods so that you can consume a reasonable amount of calories that is sustainable for you and your body. In terms of possible treatment solutions, yes, you could try some intermittent fasting, a lower carbohydrate approach, but it has to be sustainable and reasonable long term. So what I do in my practice is we look at what is sustainable for each patient. Typically, we do an intervention that is 6 weeks long. We correct the insulin resistance or at least make significant improvements, and then we cycle carbohydrates back in. So carbohydrates are not a problem. Low carbohydrate diet forever is not necessarily the solution. We need to improve the hormone response to foods, and I have other videos going deeper into insulin resistance on my YouTube channel. Kidney function looked fine. Liver enzymes were fine as well. When it comes down to the cholesterol panel or the lipid panel, it's really important that you are fasting for these. This patient was fasting 12 hours. I always recommend to my patient it's at least 12 hours for a fast. The first thing we look at is the triglycerides. I like to see triglycerides around 0.8, 0.9. When we start to see the triglycerides go up, what we see is that it could be insulin resistance, metabolic syndrome, but it could also be higher levels of hormones such as estrogen. Most commonly, correcting the insulin resistance makes improvements in the estrogen and improvements in the cholesterol panel. Overall total cholesterol 4.5 to 5.5-ish, depending on how much HDL or good cholesterol is present. So we have good cholesterol, or quote unquote good cholesterol, which is the HDL. LDL cholesterol is technically the bad cholesterol, although it's only necessarily bad based off of the particle size, which could be an entire other video. This patient, we're seeing actually pretty good levels of the HDL cholesterol. More is not necessarily better when it comes to HDL, and this is a point that I wanted to make. When the HDL goes above 2.3, this is classically seen in inflammation, estrogen dominance, so you need to have a look there. And when the cholesterol goes up, we can see issues with the gallbladder, the thyroid, hypothyroidism, fatty liver, adrenal insufficiencies, issues with, again, estrogen being elevated, insulin resistance. So it's always about asking the question, why? You are not deficient in a cholesterol lowering medication. So we need to look at, why is this a problem? How can we get to the root cause? And how can we address that underlying cause to make improvements? When we go down here, we did see an elevation in the fasting insulin. I have seen patients where their blood sugar is completely normal. The average blood sugar is normal or appears normal because their body is producing a ton of insulin to keep it under control. Insulin, when it goes up, helps to mitigate or helps to try to prevent the blood sugar from going up, trying to prevent diabetes. But if your body is producing exponentially greater than optimal levels of insulin just to keep your blood sugar under control, on the one hand, we're happy that you don't have diabetes, but it makes it really challenging to manage your weight, your hormones, your mood. We can see changes to the skin, such as skin tags, acne, discoloration. So it's really important that we have a treatment plan specifically focused on insulin and know the solution is not to eat less and move more. In terms of the thyroid function, this was actually not me that ordered this testing. This was our primary care provider. Typically, if I was to run a thyroid panel, I would also include the thyroid antibodies and a reverse T3. But this is, pretty good. At least we have the free T3 levels. Free T3 is the most important. I like to see this above 4, and I want the TSH less than 2. So I think her thyroid's overall great. In terms of, does she have elevated thyroid antibodies? We don't know from this. In terms of C-reactive protein, this tells us, is there inflammation present? Again, we need to ask the question, why? Is the inflammation raised because of the insulin resistance? Is it raised because of cortisol, nutrient deficiencies? Cortisol was not run here. Vitamin D was not run here. There's other things that we could investigate. Is there an autoimmune process going on? Autoimmune conditions can raise C-reactive protein. Did she injure herself? Was she sick at the time of this lab? It didn't look like there was a significant illness, but maybe she had done an exercise before the test. So what we really have to look at is the underlying cause. Yes, of course, insulin resistance could be the cause, but we also need to run things like an ANA and a rheumatoid factor to ensure that there is not autoimmune concerns. And the reason I'm pinpointing the ANA and the rheumatoid factor is because she does have joint pain as well. I could also consider running the thyroid antibodies. Now, when we look at what is the treatment, I always start with having a look at how we can correct insulin resistance and how we can correct cortisol issues or issues with the hypothalamic pituitary adrenal axis. In my opinion, it is blood sugar issues, stress issues, or cortisol issues that create changes to the thyroid. They can create changes to your hormones, estrogen, progesterone, testosterone. They can cause inflammation. So always going one step back further. Personally, I would have run the hormones on this patient just to get a baseline of where the estrogen, progesterone, testosterone, DHEA is. But even if I am seeing estrogen dominance in a patient with issues with insulin, we're always treating the insulin first. Now, when we look at possible treatment options, my insulin resistance presentation goes into more detail. There is nutrition options, of course. There are supplement options. I've created the BK Med Pack specifically for insulin resistance. Ideally, those are taken for 3 months. And then what you do is you repeat the fasting insulin, hemoglobin A1C, so your average blood sugar in that 3-month time, and your fasting glucose. You could also consider medications. there's medications that have varying benefits and risks and varying research support to them, ranging from anywhere from metformin to the semaglutides like Ozempic, Saxenda, Wegovy, Rybelsus, but it just depends on the patient and what the best option is going to be. In my practice, our goal is to determine what might be the best possible solution for the patient and present the benefits and risks as well as alternatives of each treatment option. So we go through, here's the benefits and risks of the pharmaceuticals, benefits and risks of the natural option, benefits and risk in dietary lifestyle, and what would happen potentially if you did nothing. So true informed consent really means looking at all of the available options and providing the patient with all of the information that they need to make the best possible choice for themselves. Now, once a choice is made, what we would look at is repeating the blood work in 3 months' time to make sure that we're on the right choice or the right direction. So if everything's moving in the right direction based off of the treatment option, that's fantastic. But if we're not seeing the results in 3 months' time, perhaps it's time to consider option B or C or a different treatment option. The vitamin D was actually run, it was 115, so that's appropriate. Anywhere from 100 to 150 is great. Now let's have a look at the genetics that were run for this patient case. Now the genetics can tell us what is an individual more likely to be at risk of, whereas the blood work tells us what exactly is going on in this specific case example. So just give me a second here. Well, I pull up the genetics for this individual. Okay, so here is the genetic report. This genetic report is from GeneRx. You simply just take the genetic information from a 23andMe health report and input it into another platform. So this is something that I do often offer for patients in my practice. So the first thing that we have a look at, and I'm really zoning in on the metabolic impacts of genetics and metabolic impacts of blood work. There are many genes that are listed in this report that have things to do with risk of cognitive decline and blood pressure and potential for performance in HIIT training or endurance training. There is lots that this test goes through. It shows what you might be deficient in terms of nutrient deficiencies, but for the purpose of this video, I'm just talking about the metabolic ones. So for this patient, what we are seeing is they are more prone to having lower levels of a hormone called adiponectin. Now, adiponectin is a hormone that's secreted by adipose or fat tissue. And the purpose of adiponectin is to improve insulin sensitivity, meaning that you don't need as much insulin to control your blood sugar. And that's the goal. We need insulin, but we need the right amount of insulin. If you produce too much of it, you are going to struggle with resistant weight loss. So this patient with the lower levels of adiponectin are more likely to struggle with insulin resistance and having higher levels of glucose, which we did see on the blood work. In addition, having lower levels of adiponectin does increase your risk of metabolic syndrome. Now, there are nutrients that we can take to help improve upon the adiponectin levels. We say we can't change the genes, but we can, through diet and lifestyle and supplementation, alter the expression of these genes. In addition, this patient has altered leptin sensitivity. Leptin is a satiety hormone. So this individual is going to be more prone to having increased hunger and not seeing the same satiation. So if we know that, we can say, okay, it's really important that we include a ton of insoluble and soluble fiber in this patient's diet. The problem with the processed foods and the foods that we're seeing in North America is they're high in carbohydrates, often high in fats, and they are low in the fibers that help blunt the response. That's going to be a recipe for disaster for patients with this genetic potential. Now, how do we help this? So we talked about the potential for supplementation, but in terms of dietary measures, this patient may want to do 2 meals within an 8-hour time period. As long as you are treating the insulin resistance and your body is able to extract calories from your storage, which is your body fat, you can get away with larger meals left often. Now, if you don't treat the insulin resistance and you start lowering your calories or lowering your food intake or lowering your meals, you are going to be hangry, hungry, and uncomfortable, and it's not going to be sustainable. So we have to look at both aspects. After 2 meals, 8 hours window for a period of 8 weeks, this patient should start to incorporate 3 meals a day, but no snacking. And this is what we do in the Metabolic Reset program. We do a very intentional 6-week losing phase where most individuals will lose 20 to 40 pounds in the 6 weeks because we're addressing the underlying issue. Then we add carbohydrates back in and we add calories back in as well. In terms of the recommendations for this patient for carbohydrates, very sensitive to carbohydrates, they make more insulin in response to carbohydrates. And we saw that on the labs, the insulin was elevated. So for this patient at the start, we want to keep grains, starches, fruits, alcohol to a maximum of 1 meal per day. This is not forever. This is for the losing phase. And then we would start to incorporate carbohydrates in the 2 meals a day. If this individual is willing to do some resistance training, they will be able to have more carbohydrates at the meals. It's an individualized approach depending on what's going on for the patient. Now, you always want to choose low glycemic index sources of carbohydrates. So really focusing on fruits, vegetables, root vegetables, opposed to the simple sugars. Proteins. This patient needs an average amount of protein per meal. They require 0.8 to 1 grams of protein per kilogram of body weight divided by 3. So you can calculate this. Some individuals require more protein. Some individuals require less protein. There is a certain genetic phenotype or profile that when you overconsume protein, it creates more inflammation, making it harder to lose weight. So this gene is particularly important to have a look at because it's promoted protein. And for a lot of individuals, this is great. Whereas for some individuals, it might not be so great. In terms of fats, this individual, it's very interesting. So you have to watch with the keto craze. Not everybody will do well on saturated fats. There are many patients that come to my practice who have tried keto and it simply didn't work, or they didn't feel great, or they gained the weight back after. So for this individual, she's going to produce more ghrelin, the hunger hormone, in response to saturated fats. So she, based off of her genetics, needs to reduce the saturated fats to less than 30 grams per day. So you could add this up simply on something like the free version of MyFitnessPal for a day or two. Look at the grams of saturated fats in MCT oil. 1 tablespoon of MCT oil, which I know individuals are dumping this into their coffee. If you have this genetic phenotype and you are getting half of your daily recommendation in your coffee, if not more, you're going to particularly struggle. So you may want to consume things like cashews, walnuts. These have much lower amounts. So I hope that was helpful. Again, this report is very long. It gives tons of recommendations in terms of vitamins, minerals, supplements, what your increased risk of, what you need to pay attention to, and pairing the blood work with the genetics can be quite helpful. So if you're interested in learning more, if you're interested to become a patient in my practice, there are going to be links in the comments below. If you want a full encompassing comprehensive lab work, we offer that as well. There's a link to Root the Health where you can see the panels that I order in my practice. There's tons of other free content on my YouTube channel, as well as if you are looking for a very guided approach to lose 20 to 40 pounds in 6 weeks time, and then keep it off. So we've incorporated a mandatory maintenance program after the losing phase of the reset program. So it incorporates both. If you are looking for, just tell me what to do, I need to get my health back on track, the Metabolic Reset program may be an appropriate fit for you. If you want to learn more, we do offer free application calls where you can meet with a member of my team, or you can meet with myself to determine whether or not you'd be a good fit for this program, as well as there's many testimonial videos or client case studies on my YouTube channel as well. So I hope that was helpful. Have a wonderful rest of your day.